Well, good morning, everyone, and thank you for joining us today. Today, we are so lucky to have the Cardiovascular Services team with us, including Jessica Beekmann, Dr. Hari, Dr. Festin, and Dr. Balaji Krishnan, and Dr. Shultz. So without further ado, I'll kick it off to you guys. Thank you so much for being here today.
Thank you for having us.
Absolutely.
All right. Well, why don't I get started here? I'm Jeff Shultz. I'm one of the electrophysiologists here and former chair of the cardiology department here on the west side. And it's just a privilege for us to get together and tell you what's been going on in cardiology and what we're looking at the future and ways that perhaps you all can help us. Currently, Health Partners on the West, formerly also Park Nicollet, I guess I should say, we have several sites, and our goal in cardiology care is to provide exceptional heart care in Minnesota and western Wisconsin, and we partner with Health Partners on the east side to also accomplish this. We have several locations. Obviously, our mothership here is Methodist Hospital and Vascular Center, and then we have several outreach sites, including St. Francis Medical Center, Maple Grove, Hutchinson, Olivia, and Burnsville. Probably one of the most exciting areas of growth are occurring in the Maple Grove area. The population is just exploding up there, and so we are seeing tremendous growth in that area. We've had the privilege of recruiting just some amazing talent over the past couple of years, and we have 4 new physicians. We have Dr. Jennifer Jew, Dr. Betty Gray, Dr. Desmond Jay, and Dr. Courtney Jordan Beckler, as well as several tremendous nurse practitioners and PAs, including Chloe Alberts, Allison Bell Potter, Claire Kupfler, Heidi Ekman, and Kelly Sword.
Good morning, Jessica Beekmann, System Director of Cardiovascular Services. Along the lines of what Dr. Shultz said, with the new faces we have welcomed in the past couple of years, this is just a quick look of what the past decade has looked like for us. We have increased the number of clinicians, which are APPs and MDs, by 66% over the past 10 years. Quick kind of facts before we get into what I would call the fun part of the presentation. Current state, our team is 37 clinicians. We have over 200 team members supporting these clinicians and providing the best care to our patients. This ranges from techs, RNs, LPNs, MAs, and sonographers. Currently, for our procedural space, we have 2 EP labs, 2 cath labs, 1 swing lab that we really flex based on the volumes and the demands. You'll hear a little bit about emergencies and STEMI care. We have to be able to provide this care to our patients, so we use that lab. We have 1 hybrid OR. You will hear about the procedures we do in that space. We share that with multiple disciplines, and that's physically located in the OR. And then also on the west side of the river, we have an IR lab and a neuro lab that's part of our cardiovascular team. Currently, if you are a patient, you would make an appointment, a consult appointment, and you'd have to wait roughly 26 days until you would have that appointment. This is actually one of the best in medical specialties, and we've been working really hard on this. Our goal is 14 days. For procedures, depending on the procedures and the resources that may be needed, we can book anywhere from a few weeks to a few months. This slide is a little busy, but the hope is it articulates the growth that we've seen year over year in the modalities that you see. So from cath lab volume, EP procedure volume, structural heart volume, and clinic volume. All of these are growing year over year. We think it's important as a department to have approach and a mission to what we are trying to achieve. So this slide is to articulate really our vision, our mission, our goals, and our strategies. I'd like to call your attention to the mission section. Really, we are aiming to be the regional leader in cardiovascular care by providing outstanding patient experience integrated clinical care and education by the way of expertise and innovation. And now I'm going to hand it over to our physicians for what I think is the fun part of the presentation.
Good morning. My name is Balaji Krishnan. I am one of the 4 electrophysiologists here. In essence, basically, we are cardiologists that specialize in the electrical system of the heart, and you'll meet my other colleagues that specialize in others. The whole idea behind what we do in our care here is we treat patients who have conditions where both they have extremely fast heart rates or very slow heart rates. And so the idea of what the present state of what we do to treat fast heart rates, we call them arrhythmias, is catheter ablation. We perform essentially all forms of catheter ablations, including complex atrial fibrillation, ventricular tachycardia ablations, epicardial ablations that any institution would be able to offer. This means we're able to treat all forms of heart rhythms with a team-based approach. So when you meet any one of us, you in essence are getting 4 of us because of how well we work as a team. We utilize the Johnson & Johnson MedTech Cardo 3D mapping system with its most advanced systems. We have a fantastic contract with them to offer our patients the best of the best that that system offers. With it, we've been able to be the only center in the Twin Cities to offer zero fluoroscopy. That means no X-ray radiation for many of our electrophysiology ablations, including atrial fibrillation, SVT, and certain things we call PVC ablations, which means in the past, for patients that were even pregnant who could not get X-ray, we can now do these procedures very safely because of the fact we've advanced ourselves so significantly. This is just a snippet of how we actually work with these remarkable robotic systems. This would be an example of 2 of us being in the room with this complex screen, about 60-inch screen, looks like a big TV you watch football on, which we can interpret so much of this. The complex images you can get out of this, use of ultrasound imaging to integrate with these 3D mapping systems. And overall, we want to call ourselves the best of the best in this technology. The second piece is dealing with heart rates that are extremely slow or things along those lines, which is where we do cardiac device implants. In 2024, we performed 885 device implants, over 6,000 device assessments. It's a remarkable size of population for the size of group we have. But importantly, we've been very focused on keeping our outcomes amongst the best, if not the best, which is we've shown 0 outcomes or complications we call pericarditis or bleeding around the heart after cardiac device implantation. We're only 1 of 2 centers in the Twin Cities to do so. No or 0 pneumothorax, meaning puncturing the lung by chance while doing these device implants. We're only 1 of 2 centers that are able to perform such procedures. This is the whole sort of, again, a pictorial of how we've been constantly evolving, how we put these devices in safe locations in the heart with the technology that's available or even with what's cutting edge with where we are today. And so as part of this, we've also become very diverse in the types of things we've had to treat patients, particularly when patients present with conditions where the solution isn't readily available. And this was the first of its kind, where in September of 2022, we had a very challenging case, a young gentleman who could not be transferred anywhere. We worked with a team-based approach between me, Dr. Jeff Shultz, and interventional neurologist to come up with a technique of being able to suck out a big blood clot within the patient's heart. It became the first of its kind in the world. And eventually now it's become a pioneering procedure for removing these types of masses with the use of what we call intracardiac echocardiography, an ultrasound camera inside of your heart. We are the only center now in the Twin Cities capable of performing this life-saving procedure. And I'm just going to show you a picture of, actually, you can see it in how the process works. Look at this big mass floating inside your heart. And here we are with this device, and we suck it right up, all right? And you can see the size of what you can do. This procedure took us an hour, 1 hour. The patient was walking in 2 hours, whereas in the past, this would be an open heart procedure, an open heart surgery that would require 1 week of full recovery before going home. And so this is a remarkable progress here created at Methodist Hospital. We're also a center. We're in collaboration with the Structural Heart Group, where we perform left atrial appendage closure devices. We're also very proud to say, because of how advanced we have become as a group with intracardiac echocardiography, to be able to perform these procedures as the only place in the Twin Cities, which means we do this without anesthesia, and patients are walking 2 hours later. We have also shown, again, our thought process has always been, how do we improve outcomes? How do we improve quality? 0 failed Watchman implants last year because we've adopted some of the latest imaging technology to make this happen. And so this is a Watchman device. At the end of this conference, I will show you some basically examples of what these things look like. Impressively, we are in the biotech capital of the world, and this device was made in Minnesota, and we're one of the premier groups doing this procedure. The last thing we do, which is to us probably the most difficult and most complicated of procedures, which we also offer, which is removal of unnecessary or damaged pacing leads from people's hearts. We have been very proud to say, in 7 years of doing this procedure, we've had no deaths in this program, where we were expected to have a 1% death rate for doing such complicated procedures. What do we see our future? As I've shown you, we're constantly innovating here. We have an amazing group of physicians, but where we want to help ourselves is with improved resources, and we hope that with our volume, we'll need some cost calculations to meet that demand. We want to be a premier center for what's called pulse field ablation. We want to be a research site for next generation technology. We have great aspirations, and we hope you can help us.
Thanks, Dr. Krishnan, for that wonderful presentation. I'm Pawan. I'm one of the interventionalists here at Methodist Hospital. I'm also the medical director of the cath lab. We like to think of Dr. Krishnan and his colleagues as electricians of the heart, and we're plumbers of the heart. So if you have any clogged pipelines that supply blood to your heart, any leaky valves, any faulty valves, then I'm your guy. Now, I like to think of interventional cardiology in 2 broad categories. Category number 1 is coronary artery disease, which is any issues with pipelines that supply blood to your heart. So if you have any blockages in the heart arteries, if you come in with a heart attack, we provide care to you. Now, we provide 24/7 STEMI coverage. STEMI is a certain dangerous kind of heart attack where an artery entirely shuts down suddenly, causing patients to come in with chest pain, crushing chest pain, shortness of breath, and when the ER physician looks at an EKG, identifies the sign of an ST elevation myocardial infarction, they page out 4 different people, including me and 3 of my staff members, and we all rush in and open up the artery. We provide exceptional care. In fact, we were the first cath lab in the Twin Cities with AHA accreditation for our STEMI program, for the exceptional service that we provide to our patients. We have a full-service cath lab, which includes various tools and devices that we can use to open up blocked arteries, including atherectomy, which is a certain kind of drill device, intravascular lithotripsy, which is a special balloon that allows us to blast calcium in the walls of the artery, laser, which allows us to basically vaporize some of the tissue to be able to make space for balloons and stents, and Impella, which is the smallest heart pump that we have that allows us to work on really sick patients. We have a high-risk angioplasty program where we take care of patients whose blood pressures are really low or their heart function is really low. We also have a chronic total occlusion program where they're able to open up arteries that have been blocked for more than 3 months. In 2024, we performed about 1,600 plus angiograms and heart catheterizations. We performed 400 coronary stent procedures, and we worked on 107 patients with ST elevation myocardial infarction. That was the heart attack that I was talking earlier. Now, we do provide exceptional care to our patients at this point, but we could do better, and we're looking for help here. We could provide next generation technologies such as OCT, which stands for optical coherence tomography, or HD-IVUS, which is a high definition intravascular ultrasound that allows us to use light as well as ultrasound on the inside of the arteries to be able to visualize the inside of the arteries. This allows us to look at the plaque and assess the plaques and put the right size stents for our patients, which can lead to better outcomes for our patients. Now, I would like to point your attention towards Exhibit A on this slide. That is an angiogram where I'm injecting dye into the coronaries of a patient. As you can see here, there are these big pipelines that supply blood to the heart, and there's smaller branches that come off of it. Now, off of these smaller branches, there are millions of microvessels that come off of it called the microvasculature. And we've gotten really good at looking at these big pipelines, but until now, we haven't had the capability of looking at the microvasculature. Now, patients can come in with chest pain that has been undiagnosed for several years, where the microvasculature isn't working the way it's supposed to. Your freeways are good, but the little lanes coming off these freeways, which are not apparent to the naked eye, are not working the way they're supposed to, causing chest pain and increasing a patient's long-term risk of heart attack. We now do have technology to diagnose this, and we would like to have that pressure wire system in the cath lab to be able to diagnose these patients and reduce their long-term risk of heart disease. Now, the second part of interventional cardiology is what we call structural heart disease, and that's where we put new valves inside the heart. We take care of leaky valves. So if you look at the left side of this slide, you see two valves that we can put in through the leg up to a patient's heart. On the right side of the screen, you see these clip devices that we're able to put on valves to reduce the amount of leakiness on a valve. Our patients are getting older, and they're living longer. And as you grow older, the valves inside the heart start failing. Now, we are able to improve their symptoms and also allow them to have more healthful years and help them live longer by doing these procedures. In 2024, we performed 130 transcatheter aortic valve replacements where we went in through the leg and put a new valve inside a patient's heart in the aortic position. We performed 33 mitral valve repair procedures through the leg called the MitraClip procedures. We performed 19 TriClip procedures, and that's where we go in through the leg and put a clip on the tricuspid valve to take care of leaky valves. And I'll show you some pictures to demonstrate what exactly that means. In the past, all of these patients needed open heart surgery, which means being in the hospital for about a week, 2 months for the chest wall to heal up, and anywhere between 3 and 12 months for them to get back to what they were doing before the open heart surgery. With these procedures, we're able to take care of the patient. The procedure itself can last anywhere between 45 minutes for a transcatheter aortic valve replacement to 3 to 4 hours for these clip procedures. Patients stay in the hospital overnight, often get discharged the next day, back to doing everything that they enjoy doing within a week after the procedure. As you can imagine, this is a huge benefit for our patients who are older and may not have the stamina and the capacity to undergo an open heart surgery. We also perform atrial septal defect and patent foramen ovale closures, and these are holes between the top two chambers of the heart. We're able to get in through the leg and put in little plug devices. And we also do what we call paravalvular leak closure, which is a rare circumstance where there's a leak around a previously deployed surgical valve, and we're able to go in and put a plug in there to reduce the amount of leakiness. We are the only program in the country that uses intracardiac echocardiography alone for MitraClip and TriClip procedures. Now, ICE technology or intracardiac echocardiography is a procedure where we're able to go in through the vein in the leg and put a catheter up to the heart, which allows us to image these valves. And these are the eyes, these are our eyes on the inside of a patient's body to allow us to put the clips at the right spot. Previously, we had to do these patients under general anesthesia, which increases risk of bad outcomes. A vast majority of these patients receive moderate sedation, which is similar to what you get when you undergo colonoscopy. There is no need for general anesthesia. Patients get discharged the next day, and it reduces the risk significantly for patients with weak lungs. Now, here's a couple videos of the TAVR procedure. On the left side of the screen, you see we have gone in through the leg, and you see the valve opening up on the inside of the patient's body, pushing the old valve to the side, and this new transcatheter aortic valve that's opening up and starts functioning on the inside of the faulty valve. On the right side of the screen, you see a picture after we've deployed the valve. The valve looks beautiful, working just the way it's supposed to, minimal leakiness around the valve. Now, like I said, we also performed the mitral clip procedure. This is a cartoon of what the mitral clip procedure looks like. We basically do this procedure under moderate sedation, like we said. We go in through the vein in the leg, which takes us up to the right side of the heart. We make a hole between the top two chambers of the heart, get over to the left side. We put the clip device underneath the valve, right where the leakiness is at, open up the clip, pull the clip back, grab onto these leaflets, and then close the clip to reduce the leakiness significantly. Now that sounds really simple, but it takes us about 4 hours to do on an average. So there's a lot of adjustments that need to be made because there's a lot of intricate movements that we need to do on the inside of the body. This is what it looks like. Like I said, we use intracardiac echocardiogram or ICE for these procedures. As you can see, that allows us to look on the inside of the heart. On the left side of the screen, you're seeing us deploying the clip. The clip has been pulled back. There are these grippers that are going up and down on the inside, as you can see. So that thing that's flailing up and down is the clip that is grabbed on to the leaflets. The clip is still open. And now that we've made sure that the clip is in the right spot, we've closed the clip, and that's reduced the leakiness. So anything that's coming back into the top chamber of the heart is the leakiness, and we've reduced the leakiness from severe to mild. Now, just like we can put the clip on the mitral valve, we can also put a clip on the tricuspid valve. And the tricuspid valve is the valve that sits between the right top and the right bottom chamber of the heart. And this space is a little bit more complex because this valve can have anywhere from 2 to 5 leaflets. And we again use the ICE catheter to look on the inside of the body, and then we're able to put the clip right where the leakiness is at. These are ICE pictures of a patient who had severe leakiness. As you can see, this is the valve, and you can see the leakiness up into the top chamber of the heart. All the red stuff that is coming to the top chamber of the heart is the bleed back into the top chamber of the heart. And we went in through the leg and put the clip and closed the clip, and as you can see, there's minimal leakiness now, and that clip is then left in place. Now, we do, like I said, provide exceptional care to our patients. These procedures are long. They can be anywhere from half hour to sometimes 7 hours long in certain cases. These procedures are done under echocardiogram as well as fluoroscopy support. Fluoroscopy means radiation. And when we're doing these procedures, we have to wear these really heavy lead aprons throughout the procedure. These lead aprons can be about 25 pounds, so imagine wearing all of that for 7 hours while you're doing intricate movements on the inside of the body. It can be really hard on the operator's back. Now, radiation is dangerous. It's something that we cannot see, and people often forget about it. But over a period of time, if you're not protected properly, it can significantly increase the risk of cancer. And we have known physicians who have had cancer in the past. If you're adequately protected, which means very heavy lead, it can lead to long-term back issues and neck issues, and that's one of the most common reasons for disability in our interventionalists as well as electrophysiologists. There are new radiation protection solutions like Rampart, Egg Medical, zero-gravity lead that allow us to do these procedures with no lead or take the weight of the lead off of us. These protect not only the physician, but also the staff that is inside the room, because at any given point, there's usually 3 to 5 other people who are inside the lab who are exposed to this radiation. The newer technology can cost anywhere between $100,000 and $200,000, and that is something that would be really nice for us to have to protect the patients, physicians, as well as the staff during these procedures. In addition, as you can see, we've seen a lot of growth, especially on the structural side. Our structural program has grown exponentially, and we keep expecting that to grow. The number of procedures that we're doing has grown by leaps and bounds, and we expect there to be new technology. There's 25 different kinds of catheter technologies that are being looked at for mitral valve replacement, which are currently not FDA approved. It's only a matter of time before that becomes a reality. Currently, as things stand, for 3 out of the 5 working days, We have two labs running at the same time, one lab where we do structural cases, the other lab where we do coronary cases, which means that we don't have another lab to often swing into in case there's an emergency or if one of the labs is down because of technical glitches or any maintenance issues. Therefore, at some point, we will outgrow our capacity, probably here in the very near future, and we would like to have another lab available so that we're able to swing into a lab, do more structural procedures, take care of patients with dangerous heart attacks in case the other two labs are taken, and eventually start doing more elective cases in those labs too. Now, these labs can be very expensive to put in because there's a lot of technology and belts and whistles that go into it, and the cost of putting in a new lab can be up to $5 million, and that is something that we would look towards you for help. Now, with that, I'm going to pass the baton on to my non-invasive colleague, Dr. Festin.
Thank you, Dr. Hari. I'm Rufino Festin. I'm one of the non-invasive cardiologists in the division. At the present time, we have 14 non-invasive cardiologists, and for the most part, we are all cross-trained in several imaging modalities. The bread and butter of multimodality imaging in cardiology usually resides in performance of echocardiograms. We do about 100 every day, and it's probably the most in the Twin Cities area. The focus is actually identifying the heart structure, function, performing stress testing as indicated. And this also allows us the ability to actually show patients at bedside or in the clinic as to what their hearts look like. How is the heart squeezing? How are the valves leaking? And whether we need to do additional testing. We read about 16 to 20 exercise and pharmacologic nuclear medicine studies each day. Again, the design is primarily identifying patients who are at risk for something bad happening in terms of having a heart attack or assessing treatment response to medications. We serve several clinics, hospitals, in-reach and outreach sites. The unfortunate thing is our present nuclear camera is approaching end of life. Now this, as I alluded to, is the bread and butter of multimodality imaging in cardiology. The fun part is actually doing cardiac CTs, cardiac MRIs, and also PET CTs. As you could see on the images here on the right, we can actually do a CT scan image of all the different major territories of the right coronary artery. We do about 30 to 40 of these each week, and this does not simply focus on coronary arteries. We do calcium scores for quantification of plaque. We also assist our interventional colleagues like Dr. Hari about pre-planning for aortic valve replacement. We also help out with Dr. Krishnan in terms of pre- and post-Watchman implant CTs. And also those who are undergoing cardioversion, there are times when we're unable to do a transesophageal echocardiogram, we could do a CT to rule out a clot. And then as Dr. Krishnan had alluded to earlier, we also do the pre-planning CTs for laser lead extraction. These studies just involve not just here at Methodist, but also our outreach sites in Hutchinson and Olympia. The other key thing which I thought was quite exciting is being able to actually detail the actual images of the heart in terms of its structure, its function, the valves with cardiac MRIs. The resolution and the images are far greater in terms of it being more crisp than transthoracic echocardiograms. We do about 12 to 15 studies a week. Our sister hospital at Regents does about twice as much with better scanner access. But the key thing with this is we're able to identify whether these patients would qualify for additional testing, such as a coronary angiogram and potential intervention. We're able to assess the type of problem as far as the heart muscle is concerned, whether this is a type of cardiomyopathy like sarcoid or amyloid or other infiltrative cardiomyopathies. We have the ability to do stress testing and even valvular assessment, particularly in the future. The current disadvantage we have is we do share scanner time with our radiology, anesthesiology, vascular surgery, and neurology colleagues at this point in time. We also have this ability to do PET CTs. Before I move any further here, we also are able to do valvular assessments with 4D imaging with terms of cardiac MRI. And this is something which is probably a gateway to the future because this will eventually become what we would consider standard of care, probably in the next 5 years or so. PET CTs is something that we would like to have, but we are not able to do at this point in time. It probably is the, I guess, the more refined version of nuclear studies that we do on a regular basis. In terms of the future state of multimodality imaging, I think it's every non-invasive cardiologist's dream of coming up with a cardiac imaging center of excellence. We do have to keep up with our peers in terms of being able to come up with the right scanners, the right equipment in terms of software, and also technologies. CT scanner technology has evolved through the years. There's a proton counting CT scanner that will be coming up in the future, which will probably allow us to image arteries well, image the different cardiac structures even better without having a lot of artifact involved. A dedicated MR scanner is something that we also look forward to, in that we could increase our volume. And in addition to that, we have certain softwares that we need to adjust to in terms of it being able to increase the sensitivity by which we evaluate studies. It takes out the subjectivity in interpreting this particular images. And finally, we also need to plan on having a dedicated cardiac MR and CT technologist, primarily more so because with we're currently sharing our technologies with our radiology counterparts at this point in time.
Before we get to showing the technology itself here real quick, we all alluded to growth is coming. As Dr. Hari stated, our patients are growing older and living longer. We have a lot of technologies that we can provide here at Methodist right now. But I wanted to show the 10-year projections and all of these modalities that we talked about and the growth that we project seeing. 27% increase. These numbers are not lost on us, that these are patients that are going to be seeking our care, and our ability to meet that demand with our current structure is not viable. So this is what we see in the future as demand. This just shows broken out in the regions across the river as an organization where we will see those demands. As you can see on the west side of the river, all of those numbers are in the positive side. So we are going to have to continue to grow in order to meet those demands. And now we will show you quick, in person, up to the camera, a little bit about, to show you what these physicians are working with.
So, and that's the thing, is that basically what I want to show you is that all of the things we're doing now were things that required open heart surgery, required major things, but now through a small IV, we're able to deliver. This is the cutting edge kind of pacing we're using now into the proper part of the heart, where I showed you the quality measures that we were really trying to achieve. And just an interesting fact, 3 out of the 4 electrophysiologists were former engineers. So we're very, very focused on making sure we offer you not only the best technology, technique, but the highest level of safety in what we do, which is why these outcomes we talked about, 0 is really a number we achieve. We strain to achieve, not even reduction in outcomes. So this is how we deliver high-end pacing technology. This is remarkable. Again, if you look at it, it would go through a little IV, but creates that, I told you, that big screen, television screen of how that intense, the map that we created creates just from this little catheter, and we use it robotically handled through this little handle here that works within your heart. It has reduced our procedure times from anything that used to be 4 to 5 hours to an hour now. But again, our goal here at Methodist Hospitals is to be the best, not amongst the best. And here's a Watchman device. It's the cutting edge technology that was made in Minnesota. It basically shrinks down like an umbrella would into a little stick similar to this system here, and we deliver this and open it and unfurl it inside of your heart. But as you can see, it fits in the palm of my hand and will go directly delivered in your heart. We're doing, again, I can't tell you, between all the presentations you've seen today, all of it is cutting edge. All of it is what you would find in any major institution. If anything, this is where you would find some really remarkable things being done.
Abby, I know we only have a little bit of time for questions, so wanted to open it up.
Absolutely. Well, first of all, thank you all for an excellent presentation. Thank you. Thank you. The work you do is absolutely amazing and so innovative and cutting edge. And so for those on the call that have questions, please enter it into the Q&A and I will read them off here. We do have a couple questions here already. So first question is, are there any plans to be able to prescribe Camzyos for HCM?
Yes, the opportunity to prescribe is there. It does take a pre-authorization process, but yeah, that certainly is a possibility.
Thank you. And then our next question here is, what is the current demand for cardiovascular care at Park Nicollet? Are you able to meet this demand with your current capacity?
So I would say we are able to meet it, but not within our patients' expectations or within a timely manner. Our organization has set out to say a patient should have an appointment available within 14 days of them scheduling. And that's back to 26 days is our current wait, and we have worked relentlessly for a year to get that down to 26 days. So current state, I would say, we are meeting the demand, but not in a way to really achieve patient experience and patients' expectations or our organization's expectations.
I would just add to that I think sometimes we have issues with just lab availability and not having enough lab time just because we're limited by space or rooms, so that procedures lag in time to be able to get them in a more timely fashion too. So sometimes the lack of additional rooms does limit us as to how quickly we can expedite care.
Thank you so much. And I thought I saw another question come in here. Yes. Can you explain the difference between AFib and having a heart arrhythmia?
Good question. And so in the world of heart arrhythmia, there are, I would say, at least 50 plus types of heart arrhythmias. Atrial fibrillation is the most common of them all right? So if you put them in a basket of things, arrhythmias is everything we deal with when the heart goes extremely fast, right? And again, we're all experts in every aspect of it, but certainly we are a major center of excellence for atrial fibrillation. I know the statistics, and we are, per person, the highest population of people that do ablation for patients who have atrial fibrillation in the entire Twin Cities. And so we're, again, looking forward to adopting more cutting-edge technology like that pulse field ablation to really meet the demands of our patients who have atrial fibrillation, but certainly there's a lot of patients who require our care in the atrial fibrillation itself.
Thank you so much. And I have a question for you as well. Back to when you were talking about pioneering the intracardiac echocardiography procedure in 2022. That's, first of all, absolutely amazing. Can you speak to the discovery process and how your team developed this procedure to make it a success?
So I think, sometimes, necessity is the mother of invention. And that was basically what it came down to. As I alluded, the initial starting point was very sick young patient in his actually 60s, early 60s, in dire straits, could not undergo open heart surgery to remove this large clot in his heart that was progressing to his lungs. Had so many reasons why, again, could not go through open heart surgery. We knew some of the technology existed, but not all the parts for us to make this safely. It was an interesting thing that we each individually knew the parts that needed to come together, and we worked with the people that were the experts at it. Dr. Jeff Shultz and I were experts in the catheter movement and things, and the intracardiac echocardiography. We found an interventional cardiologist that knows how, or interventional radiologist that knows how to suck out blood clots from the brain. Looked at his piece of technology, integrated them within a span of 12 hours, and this is the power of teamwork. I think, again, I want to speak to the power of teamwork. It was not an individual that put this together. It was a group of physicians and other members that talked about what they were experts at, how they could put it together, and in 12 hours, we were able to get this done. The patient did well, died of other causes later in time, but from this whole thing, was able to get at least a number of weeks of life left from this. But what it also meant was this was the first. Since then, we've had no one die ever from this procedure. We have saved multiple lives. We still remain the center where people ask us for expertise in doing this. So it tells you the power of teamwork. And I really want to tell you that to me meant what Dr. Nicollet's cardiac care is all about, teamwork.
That's awesome. Thank you so much. And you as a team are just such a powerhouse and doing such wonderful work. So thank you. Speaking to that, just one last question is with your care outcomes, which are so remarkable, like for example, with the 0 failed Watchman implants, can you share if there are any systems or quality measures in place that you guys use in order to have consistently good care outcomes with high quality care?
And we'll talk about electrophysiology, and I think the others can speak to, but every year we create a series of goals. We know where we don't like our safety outcomes with certain things. There's a standard that the community expects or accepts, and we want to go beyond those standards. We want not just to reduce, but the word 0 is important to us. And so we create a series of these. We talk about the approach to how to bring it to that number, and we look at it at the end of the year. And so every year for the last 3 years, we write up a quality report that we send out to the entire department that highlights what we started with, what we ended up with, and what we're going to look forward to for the next year or the years to come forward.
Yeah, I'll speak from the interventional cardiology standpoint. We're a part of registries, which allows us to put in all the data. Patients who undergo stent procedures, patients who undergo valve implantations, clip procedures. We get data every quarter where we're able to go back and take a look and see if there are any bad outcomes, why that happened, go back and see if it's a system issue, if it was a patient issue, how could we have done things differently, how could we have screened the patient. The most important thing is patient selection, because there are certain procedures that should not be done for certain patients. And that's something that we're really passionate about, that we use the right tool for the right patient. And we're constantly evolving, and we want to beat the benchmarks of the community, like Dr. Krishnan said.
And from a multimodality imaging standpoint, all the imaging labs are actually accredited. The echocardiography lab has a separate accreditation body. Same thing for nuclear cardiology. And then the American College of Radiology accredits our cardiac CT and cardiac MRI labs as a whole as well. All of them are dedicated towards improving quality and meeting the standard of care that's expected of them.
Excellent. Thank you so much. And I think we do have one more question here. My cardiologist prescribed a triple dose of LASIK. I don't know if I'm going to say this correctly, almost B2 years ago due to congestive heart failure. I'm now on hospice and can't deal with my cardiologist. Do I stay on LASIKs forever?
I think the importance of LASIK is improving congestion and improving symptoms. And so, as far as your question is concerned, if it helps with your quality of life, that your breathing is stable, I think it certainly would be important to stay on it.
Well, thank you again, everyone. And if anybody has any other questions after the presentation, is it okay if I send them to you directly, Jessica, and then we can get those answered?
Absolutely.
Awesome. You guys are all wonderful. Thank you again for taking the time out of your busy schedules to share your knowledge and innovation with us. And it does look like, let me see, let me just make sure that I don't have any other questions here. We're all good. Thank you all and have a great day.
Thank you, you too.
Thanks for joining us.
Thank you. Bye.